we're going to tell you a little bit of a story of how we started, and this has been a very long journey. We consider this to be a partnership as opposed to a one-off engagement, just to set the stage. I'm going to get us to some where we are sort of today, and then Shanell's going to give us some concrete examples of some of the work we've done together, and then we'll zoom out a little bit and talk about some of our lessons learned and some big picture stuff. So the photographs that you'll see, these are metaphors that I haven't chosen, but that colleagues of Shanell within the AWARE group have chosen. That tangled fishing line analogy of just being a square peg in a round hole, to use another metaphor. Nothing really ever fixed when you go. People intent on fixing one issue that they can concretize for themselves that makes sense to them, and not willing to take the time out to make sense of the bigger picture and the context around the acute medical illness. So that's what we're dealing in health services, but it's no better when you get to, well, my world, which is research and QI evaluation, but also just the planning around new health services and the co-design, if you get co-design at all. So what we tend to do when we're planning health services, we tend to rely on administrative data that probably isn't representative of who it is we're actually serving. And this happens over and over and over again. We inappropriately extrapolate the findings from those data and we plunk them on people who use drugs. We don't share bidirectionally. And we also promise all sorts of stuff, and then we steal it and we take it away. So there's a whole lot of pilot funding for all sorts of big sky thinking ideas, and then it's gone. And the trauma that comes with that. So there's all sorts of issues with health service planning and design. So when we started, and just, I'm going to step back a bit. I know some of you may go, why did they choose inner city? It fits for an Edmonton context. It really is a very geographically concentrated area that we're dealing with, which has its pros as far as targeted service delivery and its cons. But so it works for us. So please bear with me if it doesn't make sense in your context. But we are talking about an urban underserved population. When we set out to do our work as a group of clinicians and academics and patients, we decided that we were going to adopt the nothing about us without us perspective. Everything has to have action. Everything needs a so what and a now what. We would not rely on administrative data alone. We were always going to ask directly from the patient, what do we need here? And ask them for their, for what are the unmet needs and how do we meet them? And so, well, actually, this is a decade-old project really in the making. The Inner City Health and Wellness Program has existed officially for 5 years, but we've been working at this for many a moon before that. And what we do is we have a clinical team known as the ARCH team, Addiction Recovery and Community Health. We have a research team, that's where I'm embedded. And it's interesting being a clinician researcher because it's you get your feet in both worlds, so to speak. And we do a lot of quality improvement and program evaluation as well as that. It's not rote research all the time. And then we have an education arm. And a lot of that is boots on the ground education with people with lived experience, going and doing unit rounds, road shows, and so on. So our guiding principles are there, and perhaps I won't go through them ad nauseum in order to give Shanell more time to speak about some specific examples. But ultimately, I really like the whole patient-directed care, and I think that really resonates with us. I don't know how much it resonated with you, but I like the idea. There is shared decision-making at the planning level, not just at the individual care level. And we also have a philosophy of reducing harm. We will work with someone no matter where they're at. Everybody has worth. I don't care what your what your path is. We're going to work with you. So it's really about relationship building and trust, and that's one of our core values as a team. So I'll turn it over to Shanell to talk about some specific examples of our work.
So as you've seen in the previous slide, you'll see as an example there was just a handful of community advisory group members included there in regards to how patients are involved in hospitals. So you'll see in the photograph, Chelsea Burnham and I attended the International Harm Reduction Conference in Montreal in 2017 to co-present with Dr. Salvalaggio in regards to patients under care in the inner city. It was a good eye-opening experience. We just did a poster submission and we're a part of that. So we're both actually community liaisons, and so right now there's actually two groups. So one in Edmonton with the Addiction Recovery Community Health Program, and I sit on there as the community liaison. And so in Alberta we have a provincial drug users network, Aware Alberta Addicts Who Educate and Advocate Responsibly. I realize in the context of language, we're trying to get away from words like addict and things like that. But we actually had a group discussion at our last AGM, and we decided it was one thing to self-identify and another thing to be labeled. And so we decided at that time we would keep our name. So Chelsea is the community liaison for the group out of Calgary. And so working at hopefully the end goal is ARCH teams in every emerge department across our country, hopefully, because it's working so well for us in Edmonton. So in some of the key pieces of our work as community liaisons, so we're able to kind of bridge a gap. And when we talk about having the voice of included at the table, we're talking about people who are accessing healthcare services. And when we talk about the Aware group, it's not a 12-step group. Everyone is welcome. Currently in the group, everyone is using drugs, including myself. I recognize that I have a little bit of privilege over my peers because now the drugs that I consume are prescribed to me, and I take them as directed by my physician. And so in this current context of a fentanyl poisoning crisis that we have in our country, I realize that is not a privilege that is afforded to a lot of my peers. And so hopefully we're working toward a safe supply model to be instituted alongside the supervised consumption services that are across our country. But you can see,
at the hospital.
including in the hospital. So part of the community advisory group that we are connected to with the ARCH team, we actually have implemented the first supervised injection service for patients in hospital in North America. And so we're hoping that eventually we can get there for everybody across the country. So data collection, recruitment, and retention, making sure groups go safely. You can see some of the examples. We've been involved in regards to even the peer support role in hospital. So recognizing that peer support is an important role in hospital, we were actually able to sit in on the hiring process. And I was really taken back because after the 5 people we interviewed all day, the doctors had closed the door, Ginetta included. And so they looked at me across the desk and they said, "So who are we hiring?" And I went, "Oh, okay, well, that's our guy." The guy who says, "I've used drugs before, I've been involved in some street level stuff and had an inkling for the community." So when they're talking about involvement, they're really saying there's involvement, yeah.
So building the ARCH program, the model.
Right, so building the ARCH program, the model, like Ginetta was stating, right, they came out of the Inner City Health and Education Research Network, and when they came to community, they really, obviously, as community members, as people who use drugs, we have a vested interest in seeing the health and the safety of our community improved upon. And so that has always been taken into consideration. So we meet with the doctors quarterly. They actually come to our space. We don't ever, have to go in and, meet them in the hospital. They actually come to the community center that we work out of, and they meet with us in our space. So recognizing that there's no need to reinvent the wheel. We may have to add and remove a few spokes as we go along, but we're working on that together.
And I would say I'm not able to insert screenshots at such a late stage, but if you want to see our story of how we developed the ARCH team, and there's a lot in there about how to build relationships, and we've got 10 kind of steps to get you there. Not 12 steps, 10 steps. But you can download it at our website. It's at the bottom of the healthcare page on our website. This one I put in just to talk a little bit about, obviously, we launched the program, we spent some developmental evaluation time, there was some formative refinement time, and these guys were there every step of the way, designing, troubleshooting. We didn't understand why we were seeing certain things, certain patterns.
Hold on, that's not going to work. We'll tell you why that's not going to work.
Exactly. I don't know why. More recently, we were talking about we're seeing people overdosing in bathrooms. There's how many bathrooms? There are hundreds of bathrooms in the hospital. How do we manage that? And we got some advice from these guys about how do we manage that and keep people safe. And I just wanted to put down, I mean, we've started out the program before we had this so-called overdose crisis. I'm not going to call it an opioid crisis. It's an overdose crisis. And so we had to think fast, think on our feet, and having a strong partnership allowed us to be nimble and to modify our services, tailor our services accordingly. I don't know if you want to speak more to that.
I think it just really goes to show when the doctors came to us and they say, look, this is what we're seeing in hospital. People aren't sticking around for the duration of their treatment. What can we do? And we said, well, you need to work with people and meet people where they're at. They literally take all of our input and feedback into consideration and then implement that in a way that it's going to work in hospital for everybody, for the community that we serve, because who really knows the community better than the community?
These guys have done a lot in the way of knowledge translation in plain language. We're showing a screenshot of some of our written stuff, but we've done stuff in video. Well, we're working on a video form to try to translate knowledge from our program evaluation of the ARCH team. Do you want to talk about Streetways? I know they're super proud of this booklet.
Yeah. So we actually wanted to call it Streetways, a guide to helping you get shit. And it was like, you know, some really good tips on, you know, so oftentimes there is kind of a disconnect and a distrust when it comes to, so even, you know, working with, you know, professional social workers, nurses, doctors, oftentimes people feel like they have been mistreated or are not heard by the, you know, different systems in play. And really, so this was a grassroots thing. They said, well, what can we do to help people kind of access services? Like, what do people need to know where they can go and access income assistance, how they can get ID? Do people know about all the programs and services that are happening in the inner city? Well, probably not. So let's get them some information on how to access all of this stuff. And so this was a joint project. And yeah, so Streetworks was, we actually don't have any books left because
we sold out.
We gave them away for free, yeah. And so we gave them all away for free. And so we're working on right now doing another run for printing. But this is, yeah, definitely, it's a resource guide for people experiencing maybe homelessness or mental health or substance use issues that might not know where to go or how to access services. And some really other good tips in there, you know, to kind of ease on professionals. You know, when you're at the social assistance office, maybe it's not a good idea to tell the lady to go fuck herself when she tells you that you need to come back after 1 o'clock after the lunch break. And so, really straightforward and plain language, and easy for anyone to understand.
Yeah. Yeah, and you'll see at the bottom there's a picture of a celebration with food. And I think most of the time, if I'm giving one of these talks, usually if we were in Alberta and hosting you guys, you would have brought bannock.
Yeah.
Yeah, totally. So we celebrate with food. We try to make our spaces like round table. We want to be on an even playing field. And we definitely have celebrations because there's so many instances where it's poor them and it's, we have to stop thinking about all the garbage and thinking about what the successes are as well. So we do try to highlight that. So just some big picture for me. I'm going to zoom out now very briefly, and then the last word is really going to go to Shanell. So rethinking about what our messages are. So again, on the KT theme, but just in general, when I'm trying to design a service, maybe as a clinician, I really don't understand what it is that I'm trying to provide or what it is I need to provide. So who should be creating those messages or who should be creating those services? It has to come from a truly co-design space. So that's number one. And this is just an example of another booklet we did where I would never have come up with that being the main message or that being the main case vignette, but it worked for the community to determine how to seek care. This was a healthcare navigation booklet that we did. And then we have to rethink the messenger. And this is my favorite quote from all the qualitative research I've ever done because it is just a really powerful metaphor. This is an interaction between a professional and a couple of patients, self-identified patients. And it really is about, I was asked I was invited to come to Ottawa with you today, and I recognize that I have a so-called metaphoric car, but I'm not the driver, and it should never be me the driver. It should be Shanell who's driving. It should be Aware who's driving.
Get in, hold on.
Right? Get in, hold on, enjoy the ride. It's going to be a fun, adrenaline-filled ride, and that's good because I like them that way. Right? Right. And then rethinking the audience. And so sometimes we think that we're developing KT materials that are intended for people who use drugs, people with lived experience. And you know what? I tend to share these same materials with my residents, with my students, with my colleagues, because you learn a lot when you see things through the eyes of your patients. And so who is it that the audience is, and who's the messenger? So, go ahead.
So really, this is what we came up with in regards to relationship building with the doctors, and they really take into consideration and they take kind of direction from us. So when they're coming to us asking, letting us know about what's working well, what's not working well, we're able to, kind of fill them in on the blanks of things that they might not be seeing. So part of the Aware group is us as the provincial peer support drug user network. We go out on peer outreach, and so into the alleyways and the streets. So for whatever reason, people aren't coming into community centers to access services. Maybe they're barred. They owe somebody money. They just don't prefer not to access services. We want to go out and meet those people where we're at. And so the peers and the community advisory group actually have a really good understanding of what's going on in the community, and sometimes often from the tower at the hospital, those are things that the doctors might not know, and so we're able to work together to fill in gaps to make sure we're getting the best services and programs in place for the people who are actually going to use the services. And so what we say, these are the things that matter most to us when we're working together in this relationship. You can see, involve more than one of us. Often I heard somebody talk about that, the kind of tokenistic vibe. I liked what they said, we're this kind of same analogy that happened here where they said, you're coming with us for the ride. It's kind of the same thing. So when we talk about steadfast, committed champions, we are very fortunate in the fact that we have good community champions. So like Dr. Salvalaggio, Dr. Dong, who actually both came and did their practicum placements when they were in med school at Streetworks. And so they also have a very good feel and understanding for the community that we serve and that empathy and compassion piece, because that's kind of where they came up, and so a really good fit for us. So investing time in our relationships. We're Twitter buddies, we're email buddies, we have each other's cell phone numbers, we text each other. And she's available to me anytime I need to say, oh, hey, I've got this meeting and we were going to organize, and I just know she's there, and I can rely on having contact with her. Whenever they're visiting, they're coming to our space and meeting with us where we're at, so literally meeting people where they're at. They, all of these things, like we said, leveraging the existing resources. We don't need to reinvent the wheel. We may need to add or remove a few spokes along the way, but we're going to do that together to make sure our vehicle is running as smoothly as possible. Yes, so that's another thing. When we talk about remuneration, right, so recognizing our investment and people's time is valuable, their expertise is valuable. Oftentimes now what we see is people being compensated in gift cards. And so one of the things that we've kind of shied away from is because we're obviously a drug user group, people do prefer cash because, although drug dealers do take gift cards. It's at half of the face value of what the actual gift card is worth. And so when we're compensating people for their time, we're taking into consideration that once we've compensated them for their time, that is their money to do with as they wish. And if they choose not to go to Safeway and spend $25 on a grocery card, then that really, truly is up to them. And they actually really went to bat for us because the University of Alberta had said, hold on, we can't be giving people money. We need to pay them in gift cards. And these guys said, no, not going to happen. So when we need them to go to bat for us, they really do. And so that's
you have to be a squeaky wheel sometimes, and I think it's just that, how many big box stores are there within walking distance of where most of the people in our group live? So you have to keep that in mind. It's just out of reach in so many ways.
Yeah, because I really don't need an Indigo card for the Chapters bookstore because I know where the library is.
Yeah, right? All right.
So yeah, a couple of the documents that we've come up with. So for a guide to working with people who use substances, we've actually, so in partnership with CAPUD, Canadian Association of People Who Use Drugs, have both of these great documents that we would encourage anybody who's looking at working with people who use substances in a meaningful engagement way is to rely on both of these resources. So Nothing About Us Without Us, a greater meaningful involvement of people who use drugs, illegal drugs, as a public health, ethical, and human rights imperative, and also Purology, so a guide by and for people who use drugs on how to get involved. And these were both actually developed by and for people who use drugs.
However, they can certainly be used and wisdom gained by anyone. So we believe in harm reduction. We believe that central to the harm reduction philosophy is relationship and relationship-based care, and that is trauma-informed care, and it's trauma-informed scholarship as well. So we need to relate to one another in co-design and patient engagement activities.
So you'll kind of note in the, you're wondering, why the hell are they sitting in front of this red door that seems to be a door leading to nowhere? But actually that's kind of our logo and our symbol. And we decided when we were coming up, like when we were meeting with the doctors, what should our logo look like? And one of the guys here said, well, why not an open door? The door has always been kind of close to us. Can you So that red door means a lot. It means a lot to us. And these guys were actually out on peer outreach that day and had just decided, you know what, we're going to drop in and visit the docs. And that's allowed. Like they were able to, take a minute out of their day to stop by and say, hey, welcome guys.
So they basically photobombed us, but it was a good thing. That's it. All right. If you can't find any of those resources and you want to see them, feel free to direct message me or Shanell, or email me, and happy to forward whatever you need. Okay.